So I'm Lydia Chwastiak. I am a psychiatrist in the department. I'm based at Harborview, and we're really excited to be here. I'll let Sarah introduce herself, but as Mark said, this is kind of a special session where we're presenting two consecutive weeks on the management of psychosis in primary care. And we're doing this as part of our SAMHSA-funded Mental Health Technology Transfer Center. So let me skip ahead by way of introductions. Um, and, and talk a little bit about the center and then how these sessions are going to be a little bit different, and then jump into the didactic. And I'll be doing this week's didactic, and then Sarah will be doing next week's. So just to again acknowledge the Washington State Legislature's support for the integrated, for the PACC and the ICTP, no disclosures for the PACC folks. And while Sarah and I have no conflicts of interest, we do want to acknowledge that these sessions are coming out of our SAMHSA-funded Northwest Mental Health Technology Transfer Center. And this is a center that was funded last summer that I co-direct along with our colleague Maria Monroe-DeVita, who's a psychologist in the department, and Sarah's our director of training. And wanted to talk a little bit about the center, just kind of 2 words about it, and then talk about how these sessions are going to be different. So maybe Sarah, you can introduce yourself, and then we can talk about the center.
Happy to. So I'm Sarah Kapelovich. I'm a clinical psychologist by training and an assistant professor in the Department of Psychiatry and Behavioral Sciences here at the University of Washington. And as Lydia mentioned, I'm the director of training for this Mental Health Technology Transfer Center, which serves Alaska, Idaho, Oregon, and Washington. My area of expertise is in evidence-based psychosocial interventions for schizophrenia spectrum disorders. And most of what my work consists of is training the behavioral health workforce to be able to provide these evidence-based treatments for individuals in community mental health settings. And so this was a really exciting opportunity for me. I've worked in community mental health settings and forensic settings, both inpatient and outpatient, as well as on assertive community treatment teams. But this is the first for me of really thinking about the application of CBT for psychosis in primary care settings. And there's just some phenomenal work being done in this area, so I'm happy to be contributing to it. Believe it or not, I run or am involved in 4 echo clinics, all of which are involved in training individuals like yourselves in treatments for SMI. 2 are for team-based care, so first episode psychosis, coordinated specialty care teams, and assertive community treatment teams. And then 2 are specifically for providers who are learning group CBT for psychosis and individual CBT for psychosis.
Great. And I'm Lydia Chwastiak, as I said. I'm a psychiatrist, and my focus has been on improving the medical care of people with schizophrenia and other psychotic disorders. And so Sarah and I are very excited to be here. I've done a lot of work in primary care. I used to be a primary care provider, and I know a number of people on the call through my work at the AIMS Center and the ICTP implementation rotation. So as we said, our center is serving the region of Alaska, Idaho, Oregon, and Washington to support evidence-based practices for serious mental illness. And so we are one of 10 regional centers. This is part of a new SAMHSA network to provide technical assistance around evidence-based practices. And we're thinking about our workforce, definitely including primary care. So the reason we're here today is to really connect with you all and learn more about how much of an issue management of psychosis is in your settings, and trying to figure out how our center might best serve your training needs and your kind of help you provide high quality care. And so to that end, I'll be presenting this week, Sarah will be presenting the following next week, and then we'll be sending around a survey basically having you evaluate these 2 sessions and then asking kind of your thoughts about any further training. So the overview of these sessions, as I said, I'm the psychiatrist. I'll be talking about medical management today. Sarah, the psychologist, will be talking about more of the psychotherapeutic approaches next week. And I think what we want to leave you with after these 2 sessions is really a sense of the understanding from you the kind of how you're managing psychosis, what you're seeing with respect to psychosis in your settings, but leaving you with the, just a clear awareness that psychosis is treatable. And we'll talk today, we'll really focus on medical management, but talking a little bit about diagnosis, and then thinking about your therapeutic style and working with your patients with psychosis. And you may be managing, you may be responsible for the primary management of your patients with schizophrenia, just based on lack of referral resources. But so we can talk a little bit about that, but I think we also want to focus with you around the impact of psychosis on your medical management of your patients with chronic medical conditions, and really kind of think through how that makes management of these other conditions challenging. That's the overview of the sessions, and then I'll just kind of leap right into sort of the medical management of psychosis, and really have 3 objectives for the didactic this afternoon, and that is really to kind of think about some expert recommendations around principles that guide safe antipsychotic prescribing. And when I think about medical management, and we have a lot of expertise in the room here with Mark and Rick and you folks on the phone as well, but really thinking about if your patient has a primary psychotic disorder, there's an evidence-based approach to managing that, and we want to talk about that and focus on high quality management of conditions like schizophrenia. But I also want to talk a little bit about the use of antipsychotic medications, because there's a lot of evidence that of overutilization and inappropriate utilization of these medications. And so really talking with you all about some very fundamental principles about that, just to kind of think about your own care. But then as we think about management of psychotic disorders, what are the first-line medications for the treatment of psychosis? And then really thinking about management of side effects as part of your prescribing. If you're prescribing these medications, really thinking about what is the metabolic risk in particular, and really having an objective today for you to think about some of the changes you might make in your own approach to practice that might mitigate some metabolic risk. And so those are our objectives for today. Just background about psychosis, really talking about what psychosis is. It's a general term for a number of conditions that really, they're brain disorders that result in a loss of contact with reality. So there's a wide differential. I'll talk a little bit about some medical and neurologic conditions that can present as psychosis. Sarah will talk more next week about the psychiatric differential diagnosis. But really, making you all aware, if you're not already, that this is actually not uncommon, that 3% of people in the U.S. experience an episode of psychosis in their lifetime. And that when we think about the costs and the disability that are associated with all mental disorders, but with psychosis in particular, it's because the onset is early in teens and early adulthood. So this is a lot of years of living with disability, and that the cost, because psychotic disorders like schizophrenia can lead to such social and occupational disability. This is a lot of years lived with disability. But to highlight that the experience and symptoms vary greatly from person to person, so that there's really not a one-size-fits-all approach to management. But there are general strategies that you should be aware of. So, wanting to start this discussion with having you think about the medications you're currently prescribing. If you think about, if you are prescribing, the last couple of patients that you wrote an antipsychotic medication for, and really thinking about, is there an indication for this particular antipsychotic medication that you just prescribed, or really for any antipsychotic medication? And then, sort of beyond that, is the person that you're prescribing this for, are they part of a population that's at increased risk for adverse events? And, kind of drilling down even further, if this is the first antipsychotic medication this person's ever been exposed to, how am I thinking about that? Do I always have one that I always go to, or would I think about that differently? And so, in thinking about just the kind of health services research that's been done around the quality of care for both the treatment of schizophrenia and for the use of antipsychotic medications, this is not good news for any of us in the mental health settings or in the primary care settings. So what we know about treatment of schizophrenia generally is that probably fewer than 40%, probably about 40% of patients receive poor quality medication management. So a lot of patients are not getting high quality care, and that's just sort of an issue that is largely for psychiatry, community mental health, but sort of that reality of the quality of care issue. But when we think about just the prescriptions of antipsychotic medications, it's really kind of staggering. The quetiapine and aripiprazole are the fourth and fifth leading prescriptions in the country. There's sort of 2% of all adults receive an antipsychotic medication prescription. I mean, it's really the amount of antipsychotic medications that are prescribed in the U.S. is pretty breathtaking. And what this literature has shown us is that more than 30% of antipsychotic prescriptions are written by non-psychiatric prescribers. So this is, largely within primary care. And this is, one of the things we want to talk about today is thinking about what is your approach to writing this prescription, and to, kind of thinking through the diagnosis, your understanding of what's going on with the patient and the indication for them. So I wanted to kind of alert you to, I hope you're all aware of this. You may have even talked about this in a previous PACC session, but there's an initiative out of the American Board of Internal Medicine Foundation called Choosing Wisely. And they have this great structure to kind of think about a really safe way of approaching antipsychotic prescriptions. And I think this is true whether you're a primary care provider or psychiatrist or, psychiatric nurse practitioner, that they have 5 principles of why, they call it wise prescribing, but it's safe prescribing. And so it's really thinking about that do not, and it's more kind of, what not to do, that don't prescribe antipsychotic medications as a first-line intervention for insomnia. And this is based on the literature that this commonly happens. And we'll go through these a little bit more information kind of one at a time. But so don't prescribe antipsychotics as a treatment for insomnia. Don't prescribe them as a first choice for behavioral symptoms of dementia. Don't prescribe them for childhood mental disorders just to treat behavioral and emotional symptoms unless there's a specific approved indication. And we'll talk a little bit about that. I'm an adult psychiatrist, and I know there are a lot of family medicine folks and potentially even pediatric providers, but really thinking about what are the actual approved indications for antipsychotics in this patient population. And so thinking about children and the elderly as clearly high risk, they're both at very high risk for adverse effects of antipsychotic medications. And then really don't prescribe a medication, any of these antipsychotic medications for any indication without an initial evaluation and ongoing monitoring. And the guidelines, we'll talk about this, but the guidelines for screening and monitoring have been around since 2004. So, I mean, they're really the standard of care. And if you're going to be prescribing these medications, really thinking about, how am I doing with the monitoring? It's not particularly easy to do that monitoring consistently. And then the final point is about antipsychotic polypharmacy, and really don't routinely prescribe 2 or more antipsychotic medications at the same time. So really quick, I think these slides will be available to you guys. There's references. I will say you can certainly reach out to me through Mark, or reach out to us through the center. So if we can provide resources. But it's not to step through all of this, but just for you to see, this is from the FDA. These are the indications for antipsychotic medication. These are the medications that are approved, and these are the age ranges, sort of in the middle column, these are the age ranges for which these are approved. And if you look through that, there's only one antipsychotic medication that's approved for bipolar depression, which is quetiapine, or for treatment-resistant major depressive disorder. So really thinking about, going back to what are the approved indications, and it's not rigid. You can't not ever do something without an indication, but really thinking about if you're going to depart from the FDA-approved indications, what's the reason for doing that? So wanted to just have this by way of reference for you to be aware that there are specific indications for specific age groups across the medications, and that antipsychotics are, mainly for treatment of schizophrenia and bipolar disorder.
And just in terms of how the literature operationalizes medication resistant, or also called treatment resistant schizophrenia, it's an adequate trial of 2 or more antipsychotics.
Right. Well, we can talk a little bit. I mean, I think clozapine, I think, is a little bit beyond the scope of primary care prescribing, but I'd be curious to hear people's experience. But kind of thinking about the role of clozapine, and then even with treatment-resistant major depressive disorder, right? It's also failing to trials and medications. But so to think about, I mean, this is probably not new information for anyone on the call, but thinking about when someone presents to you with psychotic symptoms. So again, this is sort of loss of contact with reality. So these would be hallucinations, which typically for primary psychotic disorder are auditory, but they could be visual, they could be tactile, they could be olfactory. People with disordered thinking or frank delusions, often of paranoid or somatic nature. So thinking about, the first step is, have you identified this as a psychotic symptom? And then thinking about, what's my differential? And, we can talk a lot more about this, just sort of depending on how comfortable you all feel with this, but it really comes down to, is there, I think from a medical perspective, is there an underlying medical condition that's treatable that I should identify before I just assume this is a primary psychotic disorder or even a primary psychiatric condition? And so really thinking about that physical exam and the emphasis on a neurologic exam, because anytime someone with psychosis presents sort of new onset psychosis presents with an abnormal neurologic exam, that is definitely worth kind of taking a closer look at what might be driving that. And I think in terms of a careful history, psychiatry, psychology, we're all about careful histories. But in this case, really thinking about, is it possible that this person has had a travel exposure, an occupational exposure? So, kind of expanding your history if you're the first person kind of seeing this and picking up on these. Obviously thinking about the urine drug screen, is this a substance-induced psychosis? So similarly to a medical condition inducing it, could this be caused by a substance-induced, like typically stimulants, but a number of medications can lead to, a number of illicit drugs can lead to psychosis. So really ruling that out before going down the road of making a diagnosis. But then thinking about what's a potentially treatable condition that could be causing psychosis. So really thinking about HIV, neurosyphilis, depending on the age of the patient. So that would be the HIV and the FDA antibody test. And then thinking about B12 levels, and then kind of more sort of weird things like CNS vasculitis. You will see this. I mean, certainly we've seen this at the university or at Harvard View. So doing a screening SED rate or an ANA to think about, could there be a vasculitis? And then looking at the thyroid functioning. And so we typically think, and this is sort of a recommendation that's coming out of our New Journeys programs, kind of thinking about the role of an MRI in a new onset psychosis is really indicated largely if the neuro exam is abnormal. So not to do an MRI or an EEG just as a general screen. But, this is a case-by-case basis. So it's kind of a whirlwind tour, but just kind of thinking about, again, the indication, right? Is this psychosis? Am I missing something medical? And then thinking about the indication for the appropriate medications. And I want to just say, I mean, this is, again, very high-level overview. And one of the things we'd love some feedback from you guys about is, are any of these topics of particular interest to you that you'd like to see us create some resources or do more trainings around? But when we get back to the choosing wisely principles, thinking about using antipsychotic medications in the elderly. And I think there's two issues in the elderly, right? One is our patients with schizophrenia, they're getting older and they're on these antipsychotic medications. What should happen? This is appropriate use of antipsychotic medication, greatly increased risk of mortality on these medications. Just thinking about what are the ranges of dose. So the table really shows that they should be at a lower dose as they get older. And this would be sort of thinking about people in their 50s and older. So not old, at least to some of us, but kind of thinking about lower doses as people with schizophrenia get older. But I think a lot of the concern about the use of antipsychotic medications in the elderly is really around the use of antipsychotic medications to treat behavioral symptoms of dementia, and that this is really, has been known since 2005 to be associated with a 3 or 4 time increased risk of mortality. So really thinking about whether this is something that is appropriate, and it typically is not. And wanted to highlight that there are new guidelines. This is it might be 2017 or 2018, APA put out practice guidelines specifically around the use of antipsychotic medications in the elderly. So that's that link there. So again, thinking about lower doses and not using them for dementia. The children, behavioral disorders, again, very high level overview. This is also from the FDA. I think highlighting that there are 5 medications, antipsychotic medications, that are approved for use in children. They are approved for specific indications and at specific age ranges. There is no indication to use an antipsychotic medication for a child under 5 years old. And this happens. I don't treat children, but I'm just want to be very clear that this is something that there's currently no approved indication for someone under 5. When children above 5, here you can see what the indications are. They're for schizophrenia if it's diagnosed. Again, that's typically in adolescents, 12 or 13 and above. Bipolar disorder starting at age 10, and then the indications within autism. And we can talk about that a little bit if that's a specific question that you guys are dealing with. Want to highlight when we think about children, those who are at increased risk for adverse effects. This also includes youth and young adults who are presenting with a first episode of psychosis. And want to just highlight that these antipsychotic naive patients, that there are clear recommendations about the medications they should be started on, and those include risperidone, aripiprazole, ziprasidone, and quetiapine. We have a lot of resources. The one resource I should make sure you're all aware of is that there are first episode clinics around the state. That's likely to be increasing in numbers, so to be aware of that resource in your area, that these are evidence-based multidisciplinary teams that specialize in the treatment of a first episode psychosis. And so a lot of literature is coming out of the clinical trials of those interventions. So in Washington State, those are called New Journeys programs. We can talk about where those are located and the work that they're doing. But a great resource that we use, the New York program is called On Track. These are first episode clinics throughout New York State, and they're just terrific resource for patient education materials and just management of first episode of psychosis. So I'll quickly go through. I think this should be familiar to everybody on the phone. These are the ADA-APPROVED joint recommendations that came out in 2004, and just to highlight that there is, on entry. So this is like the day that you're going to start an antipsychotic medication. This is the information that you really should have before you start a medication, that first column. And then in that first 12 weeks is such a critical period to identify adverse metabolic effects. People in the first 12 weeks of treatment can gain 10 kilograms of weight. I mean, it's astonishing how much weight people can gain, especially kids. And how quickly they can gain it, and then how hard it is to lose it. And then they are 4 times the risk for diabetes. So really thinking about that first 12 weeks, weighing them monthly, and then getting repeat labs at 12 weeks. The 2 things I want to highlight about these recommendations were from 2004. The screening for diabetes, or the screening for abnormal glucose tolerance, is now really a hemoglobin A1C. So there's no need for a fasting glucose. There's also really no reason for fasting lipids. When we say lipid panels, and I know I'm surrounded by primary care providers, but we're really interested in the non-HDL cholesterol, and so that it should not be a barrier. You should really just get, let the triglycerides be whatever they are. Just get the non-fasting lipids and look at the non-HDL cholesterol. I bring this up because this is the focus of my research, and I think about this all the time, but just to emphasize to all of you about the reason that we're kind of hammering on the metabolic screening and monitoring is that premature mortality, that in the US, if someone has a psychotic disorder, their life expectancy on average is almost 30 years shorter. than the general population. And in all of the literature of health disparities, racial and ethnic health disparities, what we know is that people with psychosis have the largest cardiovascular health disparities of any group. They are, at any given age, they're 3.5 times more likely to die from cardiovascular disease. So really cannot emphasize enough the need to not be part of the problem, to not, continue to prescribe medications despite risk. The risk factors for cardiovascular disease, obesity, hypertension, dyslipidemia, diabetes, these are all almost twice as common among our patients with psychosis. And this is important, I think, not only for monitoring, but for thinking about the patients that you are treating for hypertension, dyslipidemia, and diabetes. What is the impact of psychosis, both on their ability to self-manage their illness and also on the way that you're providing the diabetes care? And Sarah will talk a little bit about kind of a therapeutic style, but really thinking about how is this affecting your management. The final point of the 5 wise points is to avoid polypharmacy. And I just bring this reference that there's actually been a meta-analysis of 147 studies of antipsychotic use, and that in the US, this is kind of national US data, that 20% of people who are on antipsychotics are on more than one, and that this rate just increased by 34% between the 80s and 2000s. And antipsychotic polypharmacy is associated with increased adverse effects, actually increased mortality, increased costs, increased hospitalization. So really, really wanting to avoid this. Interestingly, as we kind of make this a critical take-home point, there actually is emerging evidence that combinations of clozapine with some other medications may actually improve outcomes in people with very severe illness. But I think the take-home point for primary care management is still, not to be, you really should not be prescribing two antipsychotic medications.
And Lydia, if I could just add to that point, that when we look exclusively at Medicaid recipients or data sets, that we see that rate is actually closer to 40%, and that there is a racial discrepancy as well, where particularly Black men are more likely to be on multiple antipsychotics. So there's some social determinants of health that really factor into this as well.
Which is particularly bad news because African American men are at greater risk of adverse side effects from these medications. So it's sort of a perfect storm, right? So yeah, a lot of racial disparities in the care of psychosis. But really wanted to think about, can you do more to mitigate metabolic risks in your own prescribing? And really wanted to there have been a couple of reviews around AHRQ, for example, put out a review a couple of years ago looking at what are the evidence-based practices that reduce cardiovascular risk in people with psychosis. And so we're gonna stay in this box on the left about pharmacologic treatment. And it really comes down to how we use antipsychotic meds. And then, are there FDA-approved medications? This says for weight loss because this was about obesity, but it's also for diabetes, dyslipidemia. So there's, what do we know about the medications that work for everyone? How do they work in people with psychosis on antipsychotic medications? And then what can we do about kind of more judicious antipsychotic prescribing? So this is colored to alarm you that the high risk that, and to remind you that all of these medications, all of the second generation antipsychotic medications that are listed on the table, which is all of them that are available in the US, they all are associated with weight gain, and they all increase the risk of diabetes. So just to be clear, to be very open with patients around that this is a risk that is real for all of the medications. That being said, there is heterogeneity across the medications. And as you think about it, sort of think back to what was the recommendation in these youth and young adults coming in with the first episode of psychosis. Let's move them out of the high-risk medications. So really thinking about the best medications are the low-risk medications for antipsychotic naive patients. The high-risk medications, again, clozapine, special case. This is really a treatment for treatment-resistant schizophrenia. It involves it has a black box warning for agranulocytosis, so requires pretty regular monitoring. You have to be registered in a national registry and then pretty regular monitoring. So this is done in specialty settings. Although I would be curious to hear, we've actually prescribed it out of the adult medicine clinic at Harborview, so I'd be interested to hear anybody's experience with clozapine. But then olanzapine, which I bring up because so many of the patients who are present and are hospitalized early on in their illness are stabilized on olanzapine, and then we see them in the outpatient setting having been on olanzapine for 3-4 weeks already. So really trying to shift our inpatient colleagues away from olanzapine as a first-line medication for that population in particular. So really thinking about medications all have the same risk.
So I'm sorry to interrupt. This is looking at overall metabolic risk for all the conditions.
So it's about lower, yeah. So they travel together, right? I mean, it's
Sure.
weight gain, but what's interesting is the risk of diabetes isn't completely explained by weight gain. It seems like they actually directly cause insulin resistance, which is really that pharmacology is not completely understood. But the metabolic risk tends to travel together, and so they in those categories. So kind of thinking together with you guys around. So my patient's on olanzapine, right? This is something I'm actually in clinic today. So when I go back at 2 o'clock, I may see this, right? I was on olanzapine. Should I switch? And I think the questions that we want to ask ourselves is there any reason to believe that switching would improve a metabolic outcome? And when should I think about switching? And then what's the optimal strategy for switching? So I think there is evidence to support switching. And there've been a number of small clinical trials. This weight gain was and risk of diabetes was recognized. When was olanzapine approved? Early 80s, right? I mean, so this has been recognized for 30 years that this is a problem. And so people are doing clinical trials, and there's been enough evidence to do meta-analyses and say that there is evidence that people will lose weight if they can tolerate a switch. Their cholesterol will normalize, their glucose homeostasis can improve, if not completely normalize. This is actually a figure I kind of like this figure. This is from the largest clinical trial that actually looked at patients in the VA schizophrenia network. It had about 215 patients veterans with schizophrenia who were stable on either risperidone, olanzapine, or quetiapine. So they're stable psychiatrically, but they have a BMI greater than 27 and a non-HDL cholesterol that was high. I think it was like 160. So the randomized trial was, let's have them continue. We'll randomize them to continuing on their medication or to switching to aripiprazole. And this is a really great study, really well done study, because it's one of those pragmatic trials where you're like getting the care that you're getting from your VA psychiatrist, kind of looking at how did they tolerate the switch and what happened to them metabolically and psychiatrically when they had these switches. And so long story short, because it is a very long story, but the primary outcome was whether their cholesterol improved, and that clearly improved at the end of the 24-week trial. Then people also lost a significant amount of weight, which was about 3 kilograms at the end of the 24-week trial. But one of the interesting things was the trajectory of those improvements, because people whose cholesterol improved, it got better in like 2 or 3 weeks, and then it just plateaued. But the people who lost weight, they were continuing to lose weight, and then the trial ended. So it's unclear, how much weight people would lose over time. But the bad news is that what we see in our clinical experience is it's not overwhelming amount of weight. It's modest weight loss when we switch medications, and it's typically on the order of 3 or 4 kilograms, which can make a difference, right, in terms of diabetes risk.
Lydia, you may have already answered this, but it looks like Amy Bodie's asking, what was the impact on psychosis?
Yeah, no, that's it's a great question. So I think when I said pragmatic trial, it wasn't like, oh, these researchers are coming in and let's hope for the best, we're switching the medication. What was working with, when people switched, they were working with their clinical VA team. And so what they saw was, so when people were not tolerating a switch, they were switched back to their original medication, right? If they had emergent psychotic symptoms. And so there was a non-statistically significant increase in the need to discontinue and switch back. So I don't know if that's a clear answer to the question, but it seemed like a number of people were unable to tolerate the switch, but part of the clinical trial was to switch them back as was clinically appropriate. So I think the message there was the need for the careful monitoring during the switch and the capacity for people to be able to recognize the need to switch back. But in general, in these 200 people, 100 of them switched. The vast majority of them tolerated the switch. So that was sort
Did
of
they look to see for the ones that didn't, since there's a significant number that had to go back, if they actually benefited from even disrupting with a switching back?
Oh, that's a great question. I might go back and look at the original study. I don't know that they did a subgroup analysis of that, but it's an interesting question, and whether they regained the weight once they restarted. It's a really interesting question. I think the question that always comes up when we're training or just even talking to people in practice about when should I switch. I mean, it's not like, well, it's like we know we should switch, but like when is it? When should I think about switching? And I think there aren't clear guidelines, and the APA is just about that. Those APA guidelines for the treatment of schizophrenia are out for comment now. So I don't know if people are generally aware of them or they were just sent out to comment to some folks, but there will be APA guidelines for the management of psychosis that will be coming out in the next year. And it was disappointing to see that there weren't more specific recommendations about timing and indications for switching. But I think we want to go back to what we know is clinically appropriate. And so we know that clinical trials think about 5 to 7% of your body weight as a significant weight loss or weight gain. So if you're watching someone and they're doing really well, you got your first episode patient and they're starting to gain weight, it's a tough decision to say, let's think about a switch when you're doing well and you're going back to school or you're going back to work, but really being mindful that if someone gains 7% of their body weight, you have increased their 3-year risk of diabetes by 30%. You're increasing their risk of cardiovascular disease. So this is a number that should stay with you, that you should be thinking about. It's the percentage of the body weight that gives you that added metabolic risk. And I think any magnitude of weight gain that leads to non-adherence with medication, right? I mean, what do we see? People stop the medications because they don't like that they're gaining weight. I mean, that's there's nothing to do with us, right? They've done the switching because they've done the stopping if they stop taking medication. And then I think the question, it's sort of in my mind about when someone's diagnosed with diabetes, and this comes up for us, and it's a real challenge about whether we manage it. And it's been interesting for me to talk with endocrinology colleagues who are like, oh, it's okay with the olanzapine, and there's enough evidence that the glucose homeostasis is really affected by olanzapine in particular that I think we really want to be taking a look at that. This is a question for a discussion that I would love to hear Rick and Mark's thoughts about, and those of you on the phone, the Amy's or psychiatry colleagues on the phone, kind of thinking about how to switch, because people get stuck in the cross taper, and it feels like it's really different for antipsychotic medications than it is for antidepressants or even mood stabilizers, that there's really some harm in changing medications too fast. And so there's a great study that came out just last year in schizophrenia research that really looked at a number of studies about, is there clear evidence? And again, this is clinical trials, so it's kind of hard to know exactly how this would drive practice. But the bottom line is there's kind of 3 approaches, right? When you think about it, you can just stop the medication. Somebody's on olanzapine, you want to change them to aripiprazole. You just stop the olanzapine, and here's your aripiprazole. Start it tomorrow, right? So you can abruptly stop, immediately initiate. At a clinically effective dose, right? So you're not like, here's your 2 milligrams of Abilify, but it's really, here's your 30 milligrams of Abilify. So that's one way. You can cross taper where you are kind of reducing by about, that should be 25 to 50% every couple of days, and then you're gradually initiating. I think a lot of us, that's kind of how we think about it, right? They sort of have this idea that they're still on an effective dose in some weird combination way, but you're gradually taking one away and initiating the other. And then you can just overlap and discontinue, right? You're on your 20 of olanzapine, I'm going to start the aripiprazole, and as I'm titrating that up, and then, once I get to the appropriate dose of the aripiprazole, then I'll stop. So there are a couple of ways to do it. And what the study shows is that no one strategy was clearly superior. So really abruptly discontinuing and starting another one is a reasonable approach. And I think, you know, it would be really interesting to kind of talk about our shared clinical experience about it, because what I do know is that I see a lot of people, they come to me and they're kind of referred from other places, and they just don't. They're not supposed to be on the 2 meds, but they've never gone off that cross taper. And so there's our polypharmacy. I'm going to skip over the weight loss issue, and we were talking about medication.
These slides will be available, so people can check out the weight loss slides, because I think those are a pertinent topic. But there's probably a lot of questions, discussions you want to get to too.
Well, I just want to hit, because this is kind of a segue to how what Sarah will be talking about next week, is really thinking about in your own practice. So again, in an ideal world, people with schizophrenia or other primary psychotic disorders will get their schizophrenia care from a psychiatrist or from a community mental health provider. That's not really what's happening in primary care. But I know from my experience working at ICTP that our colleagues who are primary care providers in rural and frontier settings are treating a lot of serious mental illness. But that aside, even if you're not treating psychosis, you've got the world's best psychiatrists treating your patient's schizophrenia. The reality is that of the people that you're treating for diabetes, hypertension, dyslipidemia, a lot of them have psychosis. 3% of them have psychosis. And so really wanting you to think about, how is that psychosis impacting both how they're managing illness and how you're managing, how they're self-managing, and how you're managing. And the impact of schizophrenia on diabetes is really it's sort of it's a public health kind of a crisis, kind of looking at the disparities among people with diabetes. The impact of any mental disorder it really leads to increased mortality, most importantly, but across the board, more hospitalizations, more ICU hospitalizations, more rehospitalizations within 30 days, more microvascular complications. So really kind of a bad comorbidity. And one of the things, this is work from Ben Druss, looking at national Medicaid data. When we think about those HEDIS measures, what's the quality of care that we're providing? This is all Medicaid enrollees with diabetes. Anyone, if you had any mental disorder, that you were much less likely to meet any of the HEDIS measures, and certainly multiple HEDIS measures. So really poor quality care, and the poorest quality care by a long shot was people who had comorbid schizophrenia. So really thinking about, is this what we're doing as diabetes providers or primary care physicians? Is it where they're accessing the care? The reality is that this should be modifiable, right? We should be able to figure out as a group of clinical providers how to provide higher quality care for these chronic conditions. So I think I will, stop there and really talk about those 5 principles of your antipsychotic prescribing, thinking about monitoring, really rarely a good reason to prescribe multiple meds, and really thinking about all of these second-generation antipsychotic medications. Some of them much better for others than others with respect to metabolic risk, but all of them increase the risk of diabetes, and that children are at particularly high risk, and really, really thinking about the use of these medications in children and adolescents. And as Sarah said, I think the racial disparities are most prominent in not only among Medicaid enrollees, but in children and in African American children and adolescents, that there's a lot of inappropriate utilization of antipsychotic medications. And then really thinking about this poor quality of care, and how can we be part of the solution? How can we be aware of these disparities? Couple of resources, both WHO guidelines, kind of fabulous new resource just came out last year, looking at management of physical health conditions. And then this terrific international organization actually coming out of Australia called Healthy Active Lives. And they are really the leaders of bringing together physical health and mental health for youth and young adults with psychosis.
So we have a few minutes here for some discussion. So let's see what people's questions have. There was a number of different issues that Lydia had brought up, whether that's the polypharmacy, what to start as the first med, how to switch antipsychotics, and why. So curious to know what people's thoughts are. If they have questions around any of those topics. please chime in.
Hey guys, Lydia, I just really wanted to tell you this is my best thing that's happened to me all day listening to all
And your comment is the best thing that's happened to me.
what an amazing presentation and summary of this huge problem. And I guess I have to agree that when you were talking about the different ways of switching medications, and I historically have always done a cross titration, but ironically, I've tried to get the cross titration, like when I write it to completion, to try to get them off of the med I'm leaving, because I get stuck in polypharmacy all the time. That is a huge problem for me and my patients, and so. So anyway, that's how I've tried to manage it. But now maybe I should look at just cutting them off and see how that goes. I was so anxious about them getting psychotic, though.
I know, and they are too. I mean, I say it like it's so easy. Why don't you just do it? But I mean, I do this work too. I know it's not easy, and I know that that whole thing about watching the weight gain, that is terrible, to watch someone gain more and more and more weight. And you talk about it and they don't want to change. They're like, I'm going back to school. Why would I stop this medication? And it's really, that's patient-centered care, but it's hard to.
I know a lot of people have told me, I'd rather be fat and sane rather than crazy and skinny. I had one patient that often told me that, and it just makes it really hard, especially if they find a medicine that works for them. So,
for those of us that are prescribers, you guys, how long does it take to respond on an antipsychotic generally? So, I mean, that worry you've got, Amy, they're going to get psychotic. What's the window that you're thinking that's a risk for?
That's a great question.
Well, I don't know. Like in my case, it seems like a medication change. Like after I change the antipsychotic, sometimes I don't see a decompensation for 6 to 8 weeks after I make the medication change, and so
longer.
See changes, in their side effects right away, and so it's really hard to know. Because the delay in psychotic symptoms can be so long after, it's hard to really make a correlation between your medication change and their symptoms. So it just complicates it from my perspective.
Right. The other incredibly important point that I failed to make is that all of these metabolic side effects are dose dependent. So one of the things we clearly try to do is, for somebody who's coming out of the hospital on, 30 of olanzapine, at least can we get them down to at 20 or 10 or 5, is there some way that the maintenance dose can be much lower? And that's something that I've had some success with. But, in answer to Kari's question, it can be 6 months. I mean, if somebody, stops an antipsychotic medication and is off completely, I mean, it can really be a number of months before symptoms reemerge. So,
and you guys feel pretty sure they wouldn't have.
And they might have reoccurred anyway.
Well, that's true. Yeah, that's a good point. Yeah.
Well, and I also, sorry, go ahead.
I think we just have to be humble before just how effective antipsychotics are in schizophrenia, which is not very. Maybe they're kind of 50% effective. I've been doing this a long time. And, some of my patients that are working, I've got one guy that's been working basically full time for 20 years, has severe schizophrenia, is on a combination of clozaril and ziprasidone, which we did for weight. And he likes his ziprasidone because he isn't so sedated. He's more functional at work. He still has extensive, interesting delusions, but he knows when to talk about them and when not. So
he's probably seen the CBT therapist.
I think
he works too much.
I think it's the effect sizes, and correct me if I'm wrong, but between 0.29 and 0.48 or somewhere around there for all of the antipsychotics.
Yeah.
So which is around
50%.
Yeah. Yeah.
So when whatever we do, sometimes we're just seeing the vagaries of the illness, and we think it's the medicine. Hopefully, there's some relationship, and I do believe there is, and I believe there's, and as Lydia knows, I've been interested in the metabolic stuff going back many years, and I'm covering inpatient right now, and they just love olanzapine.
They love olanzapine. We're working on it.
And the challenge, I'm in a challenge right now. Right now, tomorrow, I've got to call a managed care company. So this is a young lady who had a severe manic psychotic break, her second one or third one, and who clearly has bipolar disorder and is mostly not psychotic right now. And the issue is she stabilized on olanzapine. We started lithium. We're going up on the lithium dose. What I would like to do is substantially decrease the olanzapine, or actually better, switch her over to a different antipsychotic while she's in the hospital. But the managed care says she's well enough now to be discharged. And when you're an outpatient doctor, as many of you will recognize, and you get somebody who went from terribly ill and committed and all those kind of things to now a whole lot better, and you're an outpatient doctor, and you're going to see this person now and then, and they've got all this other stuff going on out there, and they smoke marijuana now and then, and all that sort of stuff, and you're sort of saying, well, we'll just leave it to the outpatient people and make that switch from olanzapine to something else, and you go, holy mackerel, I've got a tiger by the end of their tail, and it sounds good, but man, you're talking about making those switches outpatient where somebody's kind of just barely stabilized from a really unstable situation. I always say to my residents, I say, in the outpatient deal, you're just thinking next week in the paper, Dr. Reese switches antipsychotics on patient who kills grandmother with axe. You go.
Well, on that note, there's a couple of questions in the slides that I skipped over, so I wanted to kind of get back to those questions. I'm unable to go back in the slides, but that's okay. Because can you
go ahead? You can keep talking.
So the questions were about, are the first generation antipsychotics better than, and then do you think? I didn't put the metformin slide in there, but so. Yes, first generation medications. I think Trilofan, just kind of thinking about the Katie study, is the one that I personally go to. Curious about you guys. If anybody has any other medications, certainly with the injectables, could think about Haldol or Prolixin. But yes, I think Trilofan is a great alternative. But then thinking about the weight loss and treating treating the weight gain or trying to mitigate weight gain, that there are 5 FDA-approved medications for weight loss, and none of them are particularly great for our patients with psychosis, right? Some of them, like phentermine and lorcaserin, might actually increase psychosis. And then, this Saxenda is actually a second-line diabetes medication, so would really not be an appropriate use in our patients. That's kind of a strange indication. So there are limited options to use medications that are FDA approved, but metformin is the one that has clinical trials data. It's not approved. It's obviously approved for treatment of diabetes or pre-diabetes. And so I think when I have used it for this indication, it's frequently justified by someone meeting criteria for pre-diabetes, but I have used it just in patients with unclozapine to mitigate the weight gain. The clinical trial data is 16-24 weeks. So okay, maybe they've lost their 3 pounds or 3 kilograms, and then, their life goes on after 24 weeks. So I really like to think about it in terms of it's a trial, and we're going to do it for 6 months. And if it's working, we'll continue it. And if it's not working, we'll kind of take it out of the mix because you're just kind of adding a medication. But it can be very useful, and I think there is increasing use of it just to mitigate the weight gain.